Hey everyone, welcome back to another episode of the Scrubbed In Show. I hope you've all been keeping well. This week we have with us another incredible guest. We have with us Dr. Neil Gupta, who is a consultant interventional radiologist at UHCW, which also happens to be the place I did my foundation training. He's the West Midlands IR training director. He's involved in many other things and has also launched a logbook for trainees. We have so many cool and wonderful things we want to talk about with you, Neil, but a pleasure to have you on the show. How are you today?
Welcome to the show.
Thank you. Thanks for inviting me. Pleasure to be here.
So just a bit of insight to the listeners. This episode got rescheduled a few times today because Neil is on call, living the dream of an IR consultant, which we'll touch on in a moment. He had to quickly jump into theatres, which I think was quite exciting. But Neil, we're going to take it all the way back. A young Neil, looking to go into medical school, becoming a doctor. Tell us about that. Tell us the motivation to why you wanted to become a medic.
I'm afraid I'm a very boring stereotype in the fact my dad's a doctor, mum's a nurse. My brother is 4 years older. He went to medical school at St George's, and I followed in the family footsteps and went to Imperial. I'm from Coventry originally, but spread my wings and went out to Imperial, London for medical school. 6 years, absolutely loved it. But it wasn't really going to be for me long term. So I made the decision to come back up to Coventry for foundation school. I did my F1, F2 up here. And then I got onto a run-through radiology training program. So it was the kind of early days when run-through training was a big thing. And straight F1, 2, and then straight into ST1 radiology. Did my 5 years of training in the West Midlands. So radiology training or interventional radiology training back then was only 3 years of core and 2 years of intervention. So I just did 2 years of interventional training. Then I went off to Australia for a year and a half for a couple of fellowships in IR. And then came back to as a consultant in 2017.
You gave a perfect intro, better than we did for your listening career. So tell us about life at Imperial and why and how did you realize that Imperial London was a place to practice? Because you can imagine it's a busy, bubbling city and loads of people kind of dreaming working in London. Why did you want to move back to Coventry?
So I think as a student, it's absolutely amazing. And as a young adult, it remains amazing. I tended to see my senior colleagues who are graduating and starting foundation training. They didn't seem to get the same level of exposure to more the practical sides of things. And there's a kind of a big queue. There's a lot of trainees in London, highly competitive training systems. So there's always someone in front of you to do the stuff. Whereas I came up to the West Midlands and I was at a tiny GGH in Rugby, and there was 5 house officers, 5 SHOs, and that was it. There were no consultants, nothing, no registrars. The consultant used to visit once a week for a ward round, and you did everything. You did chest drains, acidic drains, you did LPs, you did anything and everything as aspiration of joints, whatever, because there was no one else there. It was you and the SHO. They'd show you, and it was literally show one, do one, teach one kind of thing. Whereas I had talked to my colleagues in London, and they were fighting over clinical stuff. So I really enjoyed being on peripherals.
Yeah, and I'm glad you mentioned that. So obviously, after kind of final year medical school, people want to kind of work in a big, busy city, and they get kind of disgruntled and upset that they don't get shipped out to these places. Like me, initially I got to Coventry and I was thinking, why on earth? I was born and brought up in London. I want to be a surgeon. And then, like you mentioned, what happened was it was a blessing in disguise because I was able to get into theatres. I was dragged by my consultant because there was no one else. I needed help with like emergencies. Whereas, like you mentioned, in London, there's like 5 people waiting ahead of you just to hold a camera.
The perversity is that we call them teaching hospitals, but you get much better teaching in DGHs where they've got more time, things are at a slower pace, consultants have got more time, everything is just done at a different pace. And you kind of think, well, that sounds rubbish. I'm going to do 3 operations in a day. I want to do 8. No. You're better off doing 3 and doing them than actually watching 8. And that's where I think the major discrepancy is between what we call teaching hospitals and what we call DGHs.
I have to agree with that too. I think whilst a medical student, my best teaching came when we were at peripheral hospitals. I want to dive into a little bit into your experience at Imperial. So Imperial is known, apparently, don't quote me, to produce the most surgeons out there, right? General surgeons, I hear, and orthopods and all of that. Talk to us a little bit about your exposure to radiology and what sort of inspired you into that particular stream.
So my dad's a radiologist. But he's an old school radiologist, so he would go to work and he'd be home by 2:00 and he'd just shout down the phone if anyone rang him out of hours. And I thought, well, that sounds like quite a nice life. But obviously that was before CT and MRI was even invented, and interventional was in the foothills. So things are a bit different now. But I was the same. Yeah, you're right. Imperial breeds a kind of surgical mentality. I don't know why that is. I don't know. Maybe just they've got really good surgeons, really good surgical teachers, just inspiring role models. And certainly I did my surgical training with Professor Aradazi, who's now Lord Sir Aradazi, Health Minister. So I did my bachelor's under him as well. He was my supervisor for my integrated bachelor's degree in robotic surgery, and that was pretty cool. So I think maybe the mentoring scheme is more surgically mentality. But I think very quickly in foundation years, I realized that surgery isn't the future. I tended to see surgeons becoming very subspecialized. So you have the kind of, well, I think all medicine is like that, really. You know, the gastroenterologists look after the liver and the bowel, and the respiratory guys just look after the lungs. And surgeons are now very subspecialized. You have orthopedic surgeons that just do elbow surgery, just do knee surgery, and liver surgeons who just do the left hemiectomy, whatever. So I didn't like that aspect of surgery where you're very subspecialized and do a few procedures. Whereas in intervention, we do a massive array. And I guess we might come to that.
No, definitely.
Amazing.
Just taking a step back. So you went through med school, did foundation training, went into training pathway. And luckily for you, you had the exposure of a radiologist by virtue of your father. Problem is, in med school and even foundation training, the exposure of radiologist, I'll tell you it is, you want to scan vetted and you're calling up the phone and you're even going to get shouted at and you're super nervous and intimidated and you don't get taught radiology like as a specialist at med school. What have you found, or what would you recommend for students or juniors that are interested in the specialty to kind of access it, get exposure?
I think it's incredibly difficult, actually, for medical schools to try and shoehorn in radiology. The medical school curriculum is so incredibly busy that to try and something would have to be pushed out to push in radiology. Ultimately, radiology is the kind of fundamental building block of most specialties. And you can almost change the way the curriculum is taught, so it's radiologically focused. So, for example, in Warwick, they changed the way anatomy was taught to almost like to radiological anatomy. So you'd have CT scans and MRI scans of the body, and that's where you learn your anatomy for, as opposed to the olden days where you'd have dissection and plastinated models and things. But it takes a huge amount of effort and educational resource to change that mentality and mindset. So I kind of get that. And also a very tiny proportion of people become radiologists. You know, lots of people become GPs. So I understand that that's where they have to put their resource into. But you could argue the same as pathology, maybe dermatology, maybe the kind of what we would traditionally look at as the little known specialties. We can't shoehorn them all into the curriculum. So unfortunately, it just does come down to people you bump into and then just getting an enthusiasm for it and finding someone who's passionate from my end, from the training end, to enthuse you and give you the time of day to actually come and spend some time with us. So when I started as a consultant 5-6 years ago, we would have a taster week person, I don't know, 5 or 6 times a year. Now every single week I have a taster week person, and it's down to people like you, to IR juniors, to BSIRT, to enthusiastic people like med societies, RadSocs, all that sort of stuff. That kind of put those links in, and then people like me that facilitate the taster weeks, and just so many people now wanting taster weeks and all that. So it's brilliant, and we're getting there slowly with the kind of advertising and awareness of radiology and IR.
Let's talk a little bit about that now. So in terms of radiology, it has actually become very, very popular now. We're seeing more and more of our friends and colleagues who all said, I'm going to become an orthopod, a general surgeon, and they're all now radiology trainees. Tell us a little bit about the great sort of points of becoming a radiologist and then IR as well. So walk us through what are some of the greatest things about a career in radiology.
So they're two very different things, radiology and IR, I probably should say. And I'm very much not a radiologist. I just purely do IR now. But the massive draw of radiology is the I don't want to say the absence of clinical responsibility, but it's very much a finite working day, and your responsibility is finite as well. I think the real difficulty in the traditional medical and surgical specialties is the huge amount of responsibility that patient ownership comes with. And that goes from admission to discharge, but then also follow up and the social aspects, you know, getting the patients home and treating them in a very holistic manner. The nice bit about radiology, if that's the right way of phrasing it, is that you get to see fantastic pathology and be the detective and figure out what's wrong with somebody, and then you almost don't need to then do the nitty gritty prescribing the antibiotics for the lung abscess or giving the heparin Clexane for the PE that you just diagnosed. And you kind of see the clinical history delivered to you by you guys who come down with your begging bowl. You give us a clinical history. We then do the scan and we get instant gratification. Go, you're an idiot. It was not a PE. Or, oh, that was a fantastic clinical history. Yes, it's a PE. So we instantly see the kind of clinical history condensed, the scan that tells us whether you're right or wrong. And then that makes us actually really, really good clinicians, because we get 100 house officers coming down with a CTPA request, and we see exactly which ones are positive. So we know that the 5 people that were positive, those 5 house officers, and you go, yeah, that one gave a classic history of a PE. And those 95 other people gave rubbish histories of PE. And funny enough, they don't have a PE. So you actually reinforce your clinical diagnostic skills very quickly as a radiologist. And unfortunately, nobody else knows that. So your consultants on the wards just go, oh, bloody radiologist said no again. Yeah, we said no because we know it's not a PE, because we've seen hundreds of requests and we've seen every single one which is positive and negative, and we know, and we filtered them. So it's a bit like someone walking into the room, query DVT, and you know from the end of the bed it's not a DVT, because you can't have bilateral pitting edema leg swelling and have a PE. It just doesn't happen. But you have to exclude DVT. So we do the scan and we then go, yeah, oh, we were right. So we actually are really good diagnosticians, but we don't then have to take the clinical guff. I don't know, a nice way of saying that. And it's very much, you leave at 5 o'clock, you've done your hard work, and then often most hospitals have registrars overnight, or even they outsource it now. So you can get to leave and have a finite day, which, you know, people want that work-life balance.
So walk us through now. So as far as I'm aware, you have to do the core radiology bit and then move into IR. Am I correct with that?
So radiology training is 3 years of core radiology, ST1 to 3, and then you choose what subspecialty you want to do. So you can do breast or gynae or GU or nuclear med or whatever, or musculoskeletal trauma, whatever. That's an additional 2 years of subspecialty training. If you want to do IR, it's 3 years of additional subspecialty training. So it's what we call a 3+3 model as opposed to the 3+2 model. You kind of have to do all the nitty gritty that all the radiologists do. So CT, MR, ultrasound, understand all the different specialties, obs and gynae, pediatrics, breasts and everything. And then you can then open the gateway to IR. A lot of people find that very frustrating, because they're kind of like, well, I'm never going to look at a mammogram again. I'm never going to do a pediatric, micturating cystogram. But it's kind of a rite of passage, just like medical school, just like foundation training. You do a lot of stuff that you may not ever do again, but you just have to do it. And it gives you the fundamental building blocks of understanding CTMR, 3D manipulation, understand the radiation, and the manipulation of imaging, all that sort of stuff. So it is paramount, and it makes us better IRs. You can't be a good IR if you're not initially a good radiologist. But an IR is very different. You go back to being a clinician in more of a true sense of the word, not anywhere near like surgeons and medics who have absolute clinical responsibility. And as I said about imaging and discharge and all that clinical responsibility about family, just discussion with families and TTOs or de-discharge letters. So you kind of, in a way, get the good bits, which is the technical operations, without having to deal with all the looking after the house officers and the social family problems of the patients, and the nurses on the ward having to get the physios to come and do the assessments. So you kind of get the fun bit without the ward work, in a way.
So I can see why it's super popular and why all our friends have all gone down the radiology route. Do you mind telling us the distinction, for benefit of the listeners, between a radiologist and an interventional radiologist? Because the term is thrown around and I don't think people really know what the difference is.
Annoyingly, there isn't a easy differentiation, and that's why. So you'll have radiologists who do interventions, and you'll have interventional radiologists who do diagnostic reporting. And increasingly so now, we are starting to see more separation. So, but if you look at a traditional DGH, they don't normally have dedicated IRs, but they'll have radiologists who do nephrostomies or PTCs, or even an angioplasty or a rig or something, relatively straightforward. Whereas if you work in a teaching hospital, I know we've come back to that phrase again, you'll generally have interventional radiologists who have the full skill set to do all the different types of interventions. And what you'll find is in the teaching hospitals, the IRs do less diagnostic reporting. So I'm an exception to the rule because I'm a thoroughbred IR. So I do almost no reporting. I'm not really a radiologist anymore. I haven't done any diagnostic reporting for 7-8 years now.
Oh, wow.
Whereas most of my colleagues actually are both. So they try to find a happy medium between, let's say, doing 2 days of IR and 2 days of DR. Whereas I just do 4 days of IR. I don't do any diagnostics anymore. So there's a lot of crossover, and people struggle with their identity. And it depends who you're talking to as to what you introduce yourself as. I say I'm an interventional radiologist because that's all I do. But many of my colleagues, if they're talking to another person, they might say I'm a clinical radiologist or a diagnostic radiologist. And if they're talking to a surgeon, they'll say I'm an interventional radiologist. So it's an interchangeable terminology, unfortunately.
No, definitely. And I think a good way to put this into context is the example of today. So tell us what happened today when you're on call and you got that call where you had to go to theatres. And I think that will probably give a better insight into what your role is as a consultant IR radiologist. Yeah,
so I was just doing a kidney biopsy, a routine kidney biopsy this afternoon, and the surgeons were doing a liver resection, and they called me down, and they were struggling to mobilize the liver to free up a tumour, basically, to resect it. And they asked me to go up and demonstrate where the tumour was exactly with the ultrasound probe, which is obviously a diagnostic radiologist could do that. But then on top of that, they wanted me to ablate it. So because they were not able to free up the liver adequately to resect it safely, I popped a needle into the liver, a microwave needle, and I heated the tip of the needle up very, very hot with microwave energy and burnt the tumour in situ. So rather than the surgeons having to mobilise the liver and chop it out, I just intraoperatively burnt the liver tumour without having to resect it. So it makes their life a heck of a lot easier. So that was something I just did this afternoon.
Yeah, I think that's incredible. And I got a buzz out of reading that email. It feels exciting in the field. But the follow-on question is there's always these talks of the IR guys are coming in and taking the surgeon's work, right? So tell us a bit about that, and where does the distinction happen where it's an IR role or surgeons, or is there a lot of grey area and over time it gets kind of delineated?
Yeah, there is a grey area. It comes down to availability of resource and experience and expertise. So if there's a procedure that needs doing and someone's not doing it, then other people will come in to fill that gap. So for example, even in Coventry where I work, our previous interventional radiologists didn't really do many lines. So a line service was developed by the anaesthetists to do PICC lines, Hickman lines, Bard lines, all that sort of stuff. Whereas at most hospitals, interventional radiologists do all the lines. Similarly, the renal team do our dialysis lines, whereas again, most hospitals, the IRs do it. So they if you don't offer a service or a good service particularly, then other people come in and do it. So if we look at things like vascular surgery, traditionally, interventional radiologists did EVARs, did all EVARs, they were always delivered by IRs. What we found is that there's not really enough IRs delivering EVAR. So the vascular surgeons came in and said, we're going to start doing these to offer a better service to patients. So now, many centres, the vascular surgeons are delivering the EVARs. So it's kind of where there's a space in the market, so to speak, someone will fill that. So the ablation I just did, for example, my surgeons would always call me and ask me to do it. Whereas I know down the road, there are some surgeons that would do it themselves. They would just get the kit, put it into the liver and burn the tumour.
Oh, wow.
So they've kind of taught themselves the skill to be able to do that procedure themselves because there's been a gap in the market. There's not been an interventional radiologist there to help. So they've had to learn. So similarly, that was just 2 seconds ago, another interruption from a urologist. He's got a staghorn kidney, so the kidney's obstructed. And some of the urologists will stick a tube into a kidney through the skin, a nephrostomy, whereas most won't. So some of them have to teach themselves that because they haven't had good interventional radiology colleagues who've done it for them. Whereas now they all come to us, so we will do all the nephrostomies. So it kind of comes from gaps in the market as to where the surgeons kind of fill those voids. The reason that IR is so popular in UK is because we're all paid the same amount of money whatever work you do. Whereas if you work in a monetized system where consultants get paid for what they do, then there's an incentive for surgeons to do everything themselves.
True.
Why would you send any patient to another specialty if you could get paid to do surgery? So the kind of classic examples of that are things like fibroid embolization. So there's lots of court cases in America where gynecologists have done hysterectomies on patients with fibroids, and then the patients found out that they could have had an embolization procedure, and they've sued the gynecologist. In this country, the gynecologists are so overwhelmed with patients, they're happily sending them to interventional radiology because it means that their patient can have the right treatment, an embolization procedure under sedation, home the next day, rather than a major hysterectomy operation with 6 weeks recovery, 3 days in hospital. So it's kind of a no-brainer clinically. But if you're a gynecologist in America, you kind of want to do the hysterectomy.
For our junior listeners, right? So a few years ago, I heard someone say, IR is going to take over everything, right? Now that you've said that, I'm just thinking now, does this bode well for the future? If you're a budding radiologist going to become an interventional radiologist, if general surgeons and other surgeons are picking up these skills, is the career foolproof? Or would you say, you know what, IR is going to boom, especially with the innovations that we're seeing, which we'll go into in a little bit. But yeah, what's your forecast on the future?
That's a brilliant question. So a few years ago at the BSIR, the British Society of Interventional Radiology, there was a vote to say whether IR should become an independent specialty. And that was overwhelmingly supported by 80% of respondents. And that is because there was a fear that, as you just said, if anyone can do what we do, and if all the specialties start to cherry pick the little bits of IR that we do, then we will be left with nothing. That is probably more of a potential in other countries, in my opinion, because of the financial model that I've just explained. I think in the UK, we're more protected from that because of the lack of monetization of healthcare, and also a general respect. Surgeons like doing surgery, and so they're happy to send us the non-surgery, if that makes sense. So there does seem to be an understanding that it's better in our hands. And a lot of the things we do in interventional radiology are not a generic skill set, but it's guiding a needle into a organ, whether it be a blood vessel or a liver or a kidney or a stomach or whatever, wiggling a wire through it, wiggling a catheter over the wire, and then magic comes out the end of the catheter. So actually, a lot of the things we do, whether we're guiding ourselves through the cystic duct and then in through the CBD into the duodenum, whether we're guiding ourselves through the collecting system down the ureter into the bladder, whether we're guiding ourselves up from the common femoral artery up into the liver, into the hepatic artery, whether we're going to the spleen, wherever we're going, that skill set is actually relatively generic. It's guiding a catheter and wire under X-ray guidance. So there is an element of respect that the surgeons realize it's not really their realm and their remit and their understanding. So they're happy doing surgery and we're happy doing intervention. And I don't think that's ever realistically going to change, but there is a potential for some procedures. So as I just mentioned, EVAR to go to vascular surgeons, ablation could potentially go to the HPB surgeons. But it's very much a generational thing as well. So as the young new surgeons come in, it depends on what they want to do with their careers and actually if they're interested in doing that. Because actually the people that chose to do surgery like doing surgery, and what we do isn't traditional surgery.
No, definitely.
Absolutely.
I can hear the sigh of relief. I'm going to follow on Amzi's question, piggyback off it, and to make things worse, with all these innovation in terms of kind of AI, machine learning, and kind of, these platforms picking up cancer diagnosis quicker and in farther depth than radiologists. Tell us about your experience with it. Has Coventry started to kind of implement these things? Tell us a bit about that world.
So we do use AI in radiology, not in interventional radiology. So that's probably the easiest way of splitting that at the moment. There is no real AI in IR. It's not really. I mean, there's trials and things going on, but it's really in the foothills, and I don't think it's realistically going to happen. for a long time. Whereas AI in diagnostic radiology is coming in force and fast. We already use it for our lungs cancer screening. So I can't remember off the top of my head the exact stats, but a lot of people, I can't remember the age range, but there's people in their, let's say 50s to 70s, I can't remember the age range, are having low dose HRCT to pick up early lung cancers. And they get plugged through an AI computer, which picks up anything abnormal on the scan, and that gets basically reported. So the AI will say there's a 2 centimeter lump in the left upper quadrant or whatever, left upper lobe. But it always then goes to a radiologist to say yay or nay, and say, oh no, that's just an artifact, or that's just a granuloma, or that's just nothing. But the AI learns every single time that what the radiologist has told it, and it learns each time very, very quickly, and it's really, really good. But it's still not good enough at differentiating a tumor from a granuloma from a, I don't know, infarct, whatever, and you still need the human, but it will get there. But I don't think it will ever take away radiologists, because just as we've introduced radiographers, reporting radiographers for all our well, not all, but most of our x-rays, sonographers do most of our ultrasound now. And actually there are plenty of reporting radiographers that do CTs now. But the consultant role, or sorry, the doctor role, if you want to call it that, is a very specific one. And actually, if we cut out all the kind of normal junk, if I want to call it that, so the 95 house officers that came down for the CTPAs at load of rubbish, if the computer could say load of rubbish, and I just look at the 5 abnormals and I tell you exactly what the problem is. But similarly, when we do 10,000 chest x-rays in a week, it'd be nice to know which one of those look a bit dodgy, because I don't need to look at 9,980 of them, which are completely blooming normal. I'd quite like to look at those 20 that the computer goes, what's that? Or to prioritize the dodgy ones, and kind of, you know, because you've got 10,000, there'll definitely be 100 cancers in there. But where are those 100 cancers? The computer tell me, look at those ones first. They look a bit weird. Brilliant. We will pick up cancers a lot quicker, because it takes a long time to report 10,000 x-rays. And if you're at the bottom of the pile, that poor patient's at the bottom of the pile, they should have had to wait 6 weeks for their report. They could have got it reported today if the computer told us that was looking a bit dodgy. So that's where I think AI will come in and would be a massive favour, but it won't put radiologists out of a job.
So there you go, another sigh of relief. But no, I do see it helping the workflow and making things, because some of the stuff they're doing is, even the experimental stuff is crazy. Like, you can just see like how much of an impact it would have. Taking kind of a step back and moving into a different role you do, Neil, is you're the program director, and that itself has its own skills and attributes that you need. Tell us a bit more about that role, and what skills did you have to learn to kind of look after a bunch of trainees? And as you can imagine, the sentiment amongst trainees, I don't know how it is in radiology, isn't the best at the moment in the NHS. So tell us how you deal with that, the difficulties of trainees, kind of the empathy, the sympathy from point of view.
I think I think I'm young. I'm not young compared to you guys, but I've been a consultant for 6 years, 5.5 years now. So I still think I'm relatively close to training to understand what it's like. I think it's just being empathetic, really. It's the kind of duties of a doctor. It's the kind of simple stuff that we learn in comm skills, communication skills in first year medical school. It's just remembering that we're all humans, and we're not just machines, and everyone's got personal lives, and actually, you know, personal life does affect your work. Of course it does. And it's recognizing the stresses that we all have and how it impacts on our work. So I think we are lucky in radiology, because most registrars most of the time are supernumerary. So particularly in the day, everything is run by the consultants, and the registrars are almost there in a supportive capacity, massively helpful, but actually supportive. So out of hours, they are, you know, they run the show, the registrars, and they, you know, the whole system would fall apart if they weren't there. But in hours, they are really there to be educated. So there's a kind of an agreement in a way that we spend all our time teaching them in hours and spending time, you know, helping them blossom. And actually out of hours, they run the hospital. So there's kind of that unwritten rule. Whereas I think in the other specialties like medicine and surgery, you work your bum off all day in hours, and then you have to do all that again out of hours. And where does the training fit in? And I think it's really difficult because someone has to do those menial tasks. Now, to be fair, we have got a lot more clinical nurse specialists and physicians associates and all these kind of other people that have come in hospital at night to try and help with the menial tasks like cannulas and bloods and that sort of stuff. So it's meant to help. But I think ultimately and fundamentally, you still need to have a workforce issue in medical and surgical specialties where you poor guys are having to do all the grunt work and then train and learn and then do it all out of hours as well. So I think that's another rationale behind people wanting to do radiology, where you really are taught a lot, not spoon-fed, but you spend a huge amount, and it's pretty much an apprenticeship still. You kind of sit with the consultant next to them whilst they report a CT. You see how they do it. You understand it. You go away and you can report some, and then you bring it back to them. But it's always the consultant who verifies and authorizes it. So you're never really acting independently until you pass through exams and you start to do stuff independently. But the first 3 or 4 years are really quite handheld and supportive. So I think we're very lucky in radiology that we have that. So it's quite easy being a TPD in radiology, and I'm the IR TPD for the West Midlands. So I do look after DRs as well, but mainly IRs. And they are a group that have chosen to do IR. So they're a very enthusiastic, motivated group. Because if they didn't want to be there, they could just choose to do DR and have an easy life, and do a 9 to 5. They wouldn't have to be coming in at 4 o'clock in the morning last night. My colleague was in doing a traumatic subclavian artery dissection. I can't remember. It was a road traffic accident, and young patients blocked off the entire blood supply to the right arm. So went in and stented the subclavian artery and got the blood flow back to the arm. Now, I didn't know whether to say that because it's not actually very common that we're in at 4 o'clock in the morning. I think the problem is when you sensationalize it to an extent. You want everyone to know, and you tell everyone, "Oh, I'm at 4 o'clock in the morning, do stuff, and it's like a cool thing. You don't talk about it. Oh, I didn't get a call last night. That was nice on call. So 99 times out of 100, you don't come in. But when you do, you make sure everyone knows about it.
I can imagine. That kind of follows on to the question: what is kind of the day-to-day life for an interventional radiologist or a consultant? Just to kind of get that insight.
Yeah. So again, it differs where you are, who you are, and what you want to do. So if as I've said, some of my colleagues are DRIR, so they'll spend 2 days doing diagnostic reporting, going to MDT meetings, and then they'll spend the other 2 days doing IR. They might do a clinic, they'll do an IR theatre list, they might do an interventional ultrasound list, they might do some CT biopsies and drains. I have an ablation list, so every other week I have the CT scanner and an anaesthetist. I put my patients to sleep and I burn all their kidney, lung, and liver tumours. So it's really different in where you work and what you want to do. But me as a thoroughbred IR, I have an all-day Tuesday pretty much IR all day, Thursday pretty much IR all day. Friday morning is my MDT, is my clinic where I see all my outpatient clinics. Friday afternoon is my vascular MDT, and then Wednesday is my ablations in the morning, and then admin in the afternoon. So, and then in between all of that, I fit in my TPD role, I fit in my academy lead role, and I fit in being a BSIR chairperson for the membership and rules committee. So, I don't know where I find that time, and just kind of squeeze it in out of hours.
So now, give you a little bit of feedback from the colleagues that I've been speaking to, are ST1s and 2s, essentially. I asked them, so how's training going? And compared to the IMTs, for example, they did all turn around and say, you know what, we love our consultants. They genuinely take the time out to read our reports, train us and teach us. And I feel like I'm actually in a training program. So it makes sense with how everything you've said, they genuinely feel like that. Whereas when you speak to the IMTs, they're often overburdened, overworked, they've got a million responsibilities. And just because of the service, I think the consultants find it hard to fit in that training as well. Just some feedback. Radiology is doing well, I guess, because of the way it's structured as well. In between all of that, so you're doing IR, very busy, you're coming in for procedures, including the 4 a.m. ones. Tell us a little bit outside of those two roles that you've just talked about. What do you do? What other things do you get up to, including sort of downtime? What's work-life balance to you?
It's just family. I'm very lucky. My wife doesn't work. She was a nurse when we met 15 years ago. My first house officer job in Rugby, and married the first nurse I bumped into. But it just didn't work with a family. So we've got an 11-year-old and a 4-year-old, and it didn't work with her doing shifts and me doing IR. So she doesn't work anymore, and I'm very, very fortunate, because it means that I can spend as much time as I need to in my career, and she looks after the kids. But I don't really have much of a life other than family. It's, I work hard when I'm here. I'm pretty militant. I will leave by 5 o'clock. I very, very rarely stay past 5 o'clock.
I love that.
And I'm in about 7:30. So it's not stupid o'clock, and it's not. And then on a Monday is my SPA day, so my kind of admin SPA day. So again, I'll do that on a Monday. So I don't come into work, but I get that day at home to catch up with paperwork and do that sort of stuff. So my working week is quite finite. It's 8:30 till 5, and then really it's sorting the kids out, going to the park, the usual stuff. But I don't actually have any hobbies. I used to play hockey, and I used to do golf and things like that. But I do go out with the lads and holidays and things. But it's mainly just chilling out with the kids. Yeah,
I've just got a 14-month-old, and so I can appreciate how much time that now takes up. So that's another full-time job, by the way. So yeah.
And I try to support my wife, because it can be mind-numbingly boring. Not boring, that's the wrong word, but mind-numbing, looking after your children all the time and not having a conversation and stuff. So if I can look after them and let her have a bit of respite, and I appreciate that.
Absolutely.
Definitely. Going back to what you said, that you're quite on it when it comes to leaving work on time at 5 p.m. And obviously it's something that's encouraged, and yet you see trainees across specialties always staying back, thinking it's going to get them brownie points, that fear, that anxiety. How did you kind of implement this into your career, and what advice would you give? Because we know how detrimental it is, staying back hours and hours after, you're supposed to finish.
It's a culture. So as I said, I went to Australia for 1.5 years, and the culture there is completely different, which is why everyone's leaving in droves. But it's first of all, they all work a 4-day week at consultant level. Nobody works more than 4 days a week. When I came back to Coventry and I said I want a 4-day week, they thought I was mental. They were like, "What do you mean? We all work 5 days a week." And I was like, "No. You can do your full-time job in 4 days. If you extend your working day, or you do some working at home, things like your admin session can be done out of hours, all that sort of stuff." And they were like, "Wow, that's really clever." And so all the consultants said, "Oh, no, it's not for me. And then within a few months, every single consultant was on a 4-day week. And they said, "Oh, yeah, that makes sense." So I kind of changed the culture here when I got back about working. And again, the culture here was you stayed late when you were the acute IR. They would always stay till 7, 8 o'clock. And I was like, no, we're not doing that anymore. If you work hard in the day, you shouldn't need it to run over. And if you looked at the consultants that stayed late, they would often come in, faff about, let's say, and they wouldn't start the theatre list till late, let's say 11 o'clock or whatever. And so understandably, it would run 11 till 7. You're like, well, it's really obvious. Just start at 9 and finish at 5. It's the same number of 8 hours, just opposite. But because they couldn't get the patients into theatre, because they weren't ready on the wards, because that mindset had set in, oh, no one ever turns up till 10, so what's the point in getting the patient done? Whereas I was like, no, I want the patient on the table at 9, and I'm leaving at 5. So I did the same amount of work as my colleagues, but in the proper working hours. Yeah. And that just started to rub off on everyone, and they were like, oh yeah. So when I turn up at RFA, the patients are ready. The first patient is ready.
Nice.
And so we are on the table and operating at 9 o'clock, and we finish by about 4:30, finish off the reporting, and I walk out the door at 5. And that mindset is now stuck with the nurses and everybody, and they understand that that's how I operate, and they run it as that.
Definitely. And I think it's so important, and I think it's culture, and it just takes one person to kind of initiate it, act on it.
Where you say you expected to be there for the pre-ward round, whatever the hell that is, at 7:30. You expected to stay till the end to make, and it's just. It's a bit of a nonsense, really. If you change that culture and say, no, this is how we do it, boom, 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 you get the patients done, and I'll let you go. So like the nurses, there's no incentive for them to get through the patients if they know they're staying till 7 o'clock anyway. But you're like, no, we get this done, and we all leave at 5. And, oh, okay, and they buy into that culture.
No, definitely. I want to touch on this as well, and I think it'd be quite interesting for a lot of the listeners. Is tell us about this journey to Australia, working there for a few years, Some people go, they never come back. You've managed to come back. Tell us, I can imagine why people are, like you mentioned, drugs going out there, but tell us why it's so popular. Why is it so, appealing?
Yeah. I mean, I wanted to go to Australia for medical school, and obviously you have to do your foundation 1 year. And I did my foundation year and met my wife, my now wife. And I said to her, "Oh, can we go to Australia?" And she's like, "Well, we've only just been going out like a month. Can we just hold off a bit?" And then I was there for 2, and then I got into run-through radiology. And I was kind of like, "Oh God, I've just literally been given a run-through radiology training program. I really can't just turn that down and bug off to Australia." So I kind of put that on hold. But I said to my wife, "Promise me when I finish my training, we can go to Australia." So she did give me that promise. So I finished my CCT. I had got a job here as a consultant already. So I interviewed in my final year, ST5 year, and got a consultant job here. And then I said, "By the way, I'm bugging off to Australia for a year." And they were exactly of your opinion, like, "Oh, you're not going to come back. Like, oh, we're just giving you a consultant job." And I don't care, I'm going. So we packed up our house, put it all into boxes, rented it, sold one of our cars, and were pretty much kind of very open to the idea of staying in Australia. Went there, lived in a massive house with a pool on the beach.
Oh, man.
Lifestyle was off the scale. My salary was double my consultant salary. So my fellowship salary was double my consultant salary. I mean, it was just obscene amounts of money I was earning. As I say, the culture is it's kind of like an 8 till 4 day. So you start early, finish early, get home and go for a surf, whatever, or swim, jump in the jacuzzi. I mean, it's mental. And that the first year was absolutely incredible. And I extended my fellowship by another year, and I applied to stay. So I applied to the Royal College of Radiologists in Australia to do their, local, what do you call it? Where they assess you to see whether you're equivalent to their trainees locally. Annoyingly, they don't accept the FRCR UK exam. So if I wanted to stay, I would have had to do the local Franska exam, the local radiology exam. I'm not very good at exams, and I wasn't a very good radiologist. I'm a really bloody good interventional radiologist, but I didn't really like radiology that much, and I couldn't put myself through the exam. And also after a year, we started to get a little bit bored. You're really isolated. It's really far from anywhere. I was in Perth, so 4 hours to Sydney, 4 hours to Bali, 7 hours to South Africa. That's it. There's nothing else around you. Massively isolated, obviously no family. And culturally, it's just different. They're quite insular. They don't really care about the rest of the world because it doesn't really affect them. And we just found little things started to tease us and think, this is probably, I could stay there for 5 or 6 years, probably very happily, and a hell of a lot of money. But we didn't see it as a long-term solution. So, grandparents back here and all that sort of stuff. We knew it wasn't going to be a forever thing. And we thought, well, what's the point in having 5 or 6 years and then coming back to the UK? We may as well come back to the UK and make roots and properly. So the main thing was I did not want to do the exam. And the second of all, this kind of cultural distance and the classic things I imagine. But while you're young and energetic and all that, that's the best time. And if you do your training out there, it's kind of a no-brainer. So I'm afraid I am advertising people to leave the NHS. I missed the boat, maybe. Because it's just, unfortunately, it is just better. The working conditions are really good. But it's really, really far, and there's a lot of downsides as well. And the problem is, when it's a bit like anything, the honeymoon period is about a year. And you it's amazing for a year, but after that, it starts to wear thin, and you think, the things that I love about the UK, and you miss those little things, and family and friends and history and culture and Europe on your doorstep and all that stuff that you can read on any website, but it does become real. That's what I'd say.
No, definitely. And I think you're right. As in, most people we speak to, they do like 2-3 years and then they kind of fly back. And it's not the lifestyle, it's not the money, it's the little stuff, kind of family, friends, UK, London, as miserable as the weather is. People do tend to miss it. And I think it's difficult when you're kind of born and brought up in a place like Europe, UK. People do miss it and tend to come back. The other question I had, and I wanted to ask before, and it's completely off a different tangent. When working in IR, you're kind of exposed to all of this radiation. I imagine you have to wear the lead things. I recently heard that, there's this anxiety and concern that, is it safe? Is it healthy? Despite all the protective measures, there is still exposure, right? How do you feel about that? Do you worry about the future?
No, in a nutshell, in ST1 radiology, you get a lot of radiation protection training and education and understanding about how it works and what it is and what it does and all that sort of stuff. And I think if you take it seriously at that stage and understand it robustly, then the amount that we get is really small. When you can contextualize it to doing an international flight or whatever, or living in Cornwall, they always say, because there's radon in the rocks. It's really not of major consequence. And particularly if you are someone who does, let's say, 2 days a week of IR, it's not you're not in there every single day radiating yourself. And if you do take the simple measures, like, as you say, wearing the lead apron, I've got my lead glasses here that are lead lined, and I've got lots of monitoring. So I've got a ring that monitors my radiation dosing. I've got a monitor on my glasses. And I've also got a body monitor as well. So I'm constantly being monitored on my radiation levels. And we get audited every single month, and we get a feedback on what I've never in my entire career ever exceeded a dose. So there's very strict doses and legal constraints. And if you ever breach one, you basically have an investigation to understand why you breached it. So I think all of my colleagues have breached over the last few years. I've never breached, and because I take it seriously. Little things that you learn about, like coning, so reducing the amount of X-ray, not pressing the foot pedal all the time, taking a step back when you do an angiogram, all that sort of stuff. The little tiny things that you learn in training. It's just negligible. So I think if we look at some operators that do get doses, it's nearly always their bad practice.
I was at work and someone said there was like this. Like an interventional cardiologist, and then he ended up getting like a brain tumor, and he was like, you can imagine, he's like, he works his whole life doing it, and then and then I was thinking about it, so I'll ask you.
No, you do hear about that all the time, but I guess it's it's a really bad example, but I was going to say it's a bit like when a doctor commits suicide. That we portray it as being very, very common, and it is more common than in the natural population, but it's not an everyday occurrence, thank God. But yeah, we do have higher alcoholism, higher suicide, higher depression in medicine. We know that, and we accept that and understand that. So you could say that it's akin to that. You know, you may well have a higher instance of radiation-induced problems, just as you would, but you're more likely to probably become an alcoholic in medicine. So unfortunately,
that's a nice way to put it, and it puts things into context. A few more questions before we let you go. We know you're on call. Tell us a bit more about, is it pronounced Tirtl, this logbook that you founded? Yeah. Tell us. So I love it when kind of people do side hustles, things outside of general conventional medicine. Tell us how you got off the ground. Where did the idea come from? You know, tell us a bit more about it.
So it's pretty much when I became the training program director for IR in the West Midlands. I used to sit on the ARCP panels. So the annual review of all the trainees, and I would get sick to death of reading through hundreds of different portfolios that were all kept in different ways. So people would classify different things as different. So you almost get an Excel spreadsheet for one person, a PDF as another, a Word document another, and then literally scraps of paper that have been scanned in, handwritten notes. I did a nephrostomy today and a PTC the other day. You're like, my God. So to try and disseminate that and break it down to understand what people were doing, and to then compare them to peers to see what other people had done at that level of training was impossible. So I wanted to standardize it. So selfishly, I used my own logbook that I developed when I was a trainee. And I also looked at lots of other logbooks that colleagues had kept. And I kind of distilled them down to all the different procedures in IR, the kind of levels of training, supervision and things like that, and came up with a logbook, which I then ran through the BSIRT. I ran it through my local trainees, and I trialed it in the West Midlands amongst my guys and girls, and got a lot of feedback, edited it, and then I presented the idea at the BSIR council. So I took it to the BSIR and said, can I have some money to fund this into a web-based platform? And fortunately they did. They gave me a lot of money. I worked with a digital company to produce the website. And now we have over 300 users of the website internationally, all over the world, America, Middle East, Australia, and obviously UK. So there are trainees all over the world using this logbook now, which is fantastic. And it just standardizes people's ability to present the data they're doing it, the procedures they're doing. And yeah, it's been a really good, fun journey.
No, definitely. The question is why? So in medicine, there's a lot of problems. right? And not many people go out and find solutions or try to do anything about it. Why did you go and do it? What was your mentality? What was your rationale, right? Because I'm sure other individuals on the panel had the same problem, but what made you different to go and do something about it?
Well, to an extent, it was selfishness, because actually, I'm probably gonna be TPD for a few years, and every time I sit on the panel, I get the same problem. So it makes my life easier if then everyone is standardised. So maybe it's just being selfish, but maybe I'd like to think I'm altruistic and think it's good for everybody. I mean, I get no financial reward out of this at all. You know, this is completely free. I get no money out of this at all. It was just purely to have a standardized logbook, which helps my ARCP process. So maybe I'm selfish, but maybe I'm altruistic. I don't know. I'll let you decide.
Yeah, I think in my head is you saw a problem and you found a way to make it easier, and you came up with a solution and implemented it. And I think there are lots of people that would have suffered and they just wouldn't have done anything about it, even from a selfish point of view.
Almost, I mean, you know, this is why I have no hair, and you know, I didn't shave this morning. I'm grey as well. So if you see a full-headed hair doctor, I guarantee you he isn't doing stuff like this. But the bald grey ones are the idiots like me that take on projects that we're not paid for. It's, even the BSIR role that I hold, so I'm the chairman of the British BSIR Membership Rules Committee. That's, again, it's not paid, it's not remunerated, it's in your own time. I had a meeting yesterday morning for a council meeting. So this is all in your own time, but it's to the betterment of the specialty. It's networking with colleagues to understand how things are done differently. It's at the moment we're working on a grant scheme for people to attend BSIR, and we're going to give them educational grants, because obviously study leave budgets are being squeezed nationally. So we're going to try and come out with funding to help people attend these conferences. So yeah, maybe I'm a saint. I'm trying to help people, but my main enthusiasm is IR and getting it out there, getting people to understand what it is we do and how we do it, and getting more trainees into it and enthusing them.
To talk a little bit about the log booking system now. I think from the junior end, you can get a bit of disgruntled juniors who say, damn, I have to log this and log that. Tell us a little bit about actually why, from the director end, from the more sort of consultant end, why it's important to have a logbook. Because sometimes it just passes us juniors and we think, oh, actually it is. Once you get to that stage, it's really important.
It's really important, yeah. So if you ever do have a complication, you know, to say that you've done X number, it really helps. I mean, I'm very fortunate. I've never had a major complication that's ended up with a death or a coroner's case. But if you're standing in front of the coroner and you've had an unfortunate mistake or complication, if you can say, I've done 400 of these and they've all been completely fine, and this is just a one-off, but you say, oh, it's the first time I've ever done it, it's a completely different kettle of fish. And if you've got a logbook that shows you've done 20,000 operations and only had one or two complications, it's a very different mindset. And I know we shouldn't live in that society, but we have to be realistic that litigation is getting worse in the NHS, you know, and we do have to protect ourselves. And patients no longer see us as, you know, certainly don't see us as gods or anything, but they are very happy to complain. So we do have to protect ourselves, and from complaints and criticisms. So having a logbook it just gives you a bit more robustness.
Absolutely,
no, definitely. It's super important. The final question, and I know lots of people will probably be keen to hear, is from your experience dealing with trainees, and radiology is getting super competitive. Definitely more so it was a few years ago from what we've heard. How do people put in a competitive portfolio? How do they get onto a training program? What are the things you like to see and that you would encourage them to do?
Yeah, it's a really, really good question, because recently the application has changed. So the application that was just in December, wasn't it? Or in December that it's opened, didn't it? Was just almost unachievable for most people. We at training level, at my training level, don't have any, you know, say or anything on that. That's at that more national level. But in my day, it didn't seem that difficult. You did an audit, take your taste a week, and you know, talk nicely at interview. But now you need to kind of present a national conference, run an international training program. You know, it's just bonkers. But the rationale or the reason behind that is because they can. So as you just said, the competition is just becoming so incredibly high. They need to find a way to discriminate people. And unfortunately, there are crazy people like you that run a national podcast, which not many people do. Or there are crazy people that run a national course. So there are people that have done a PhD. And annoyingly, those people will do better on the application because they have done something extraordinary. I don't think, with no disrespect to you, it makes them better because the skill set, it might give them certain skills that make them better in one remit, but not in others. But it's just there has to be some way of discriminating people, because how otherwise do you know all the Abduls of the world are the same? So we, if I want to put myself into that pool, can afford to be picky, let's say. So
makes sense.
I don't fully subscribe to the difficultness of it now, but I get it because we can afford to be picky. A bit like the Australians on their visa applications. You've got to be under 40, and they can be picky because everyone wants to go there, so they'll make it really difficult for you.
Exactly. For me, I hope there's a better system in the future, though, because I've seen the general surgeons, basically the CSTs, those guys, the number of hoops they have to jump through to get a training number or a core surgical post is incredible. So, like, as an F1, F2, you have to have completed all these things, as you've said, international conferences and stuff. And there's no real, I think, direct sort of link to them being a great future surgeon. But you're right. How else do you separate 1,000 people all applying for that one post, and they're all actually great people and great potential surgeons? But I hope someone clever comes up with something else that can sort of predict that better, I guess.
I mean, I remember when I applied to medical school back in 1990 something or other. It was actually, it wasn't that far ago, was it? Yes, it was 1999. Wasn't it? Yeah. Anyway, I remember Nottingham had a psychometric analysis test for medical school, and what I think they were doing as a pilot, whenever they actually looked at it, I'm not sure, to try and see the type of people applying to medical school and actually whether they predisposed to depression or whatever, or predisposed to high flying people. I don't know. They were doing psychometric analysis. I never saw the results of all of that sort of stuff, and I think they kind of got rid of it a few years later. But it's the same thing as what you're alluding to. Does it presenting a national conference or running a national course, does that make you a better radiologist or surgeon or GP or whatever? Or actually, does a psychiatrist need to assess you almost to understand whether? And I suspect probably the latter. But then that just opens a whole new can of worms. We're then discriminating on psychiatric ability. So I guess it's a less. Maybe it's an easier thing to discriminate on kind of achievements, as opposed to saying, well, actually, you're crazy, you go and be a surgeon, or you're very lovely, go be a dermatologist. I don't know. But
I know.
I suspect there is. I suspect if you did the psychometric analysis on all orthopedic surgeons and then on all psychiatrists, I suspect there is some common theme, because people do choose. I remember going to medical school with a girl who was very lovely, and she wanted to be a geriatric psychiatrist. And I was like, bloody hell, who wants to be a geriatric psychiatrist? Typical, and we do stereotype here, the typical rugby playing lad, and you know he's going to be an orthopedic surgeon, and he does become an orthopedic surgeon. So it's not stereotyping an old wives' tales for no reason. There's probably an element of truth in that. But I don't know if we're ever going to get in a situation where we do psychometric analysis to say you would be really good. You would be really good as a pathologist, because that kind of says, does that mean I like dead people or whatever you want to into stereotypes?
Definitely, and I do agree with you. I think the biggest thing, the core, is they can ask for it, and they know year in year out people will live up to those standards and criteria, and it's a super easy way. You fit it, you're in, you get into it. If not, you do something else. I do feel for you guys and everyone applying. I do absolutely appreciate. I would never get into radiology training anymore. I wouldn't even got to do training because nowadays you have to pass your part 2A by ST3 and the 2B by ST4. I was in ST5 and still didn't even have my 2A. So I was way out. But because I spoke nicely, came across nicely, and a hard worker, I kind of got away with it. It's just not allowed anymore. The system is so stringent that I would have just been kicked out of the scheme at the end of the third year. You just mentioned something, and I think it's important we talk about it. in medicine, to do well and to progress in your career, there are other things that are important. It's not just being kind of book smart and kind of knowing things A to Z. It's the soft skills. Tell us a bit more about that, because I think clearly, obviously, due to kind of the nature, people are a bit more disgruntled, people are a bit abrupt and stressed out. But how important are these soft skills to progress and do well in a career?
More important than anything, because I don't know if this view is controversial, but I don't believe you can teach those skills particularly well. I think, we try, but some people aren't particularly empathetic, or they are in their soul and their heart, but they don't come across as it. And I always used to you're probably too old to remember Gordon Brown, but I kind of remember a very vivid interview where he'd obviously had an earpiece and he's just a grumpy git, and then someone's always said smile, and he just has this insane grin. And it's just not his thing to smile. But his PR person is saying, "Oh, you've got to smile, you've got to kiss the baby," and he'll get the baby and do something inappropriate. It's like, no, because he's just not. That's not his thing. But he's being forced to do it. So I'm not entirely convinced you can force empathy and the soft skills that we talk about. They're actually quite natural. Whereas technical skills, you can. Yeah. So I can teach you to puncture a femoral artery. I can teach you to manipulate a catheter into a liver, but I can't teach you. Well, I can try to empathize when that patient has a complication, to avoid the confrontation with the family when they're bleeding out. Those skills don't come across very often. When they do, that's when you step up to the plate and earn your stripes as a doctor or as a consultant. Most of the things that we stereotype doctors as being able to do, anyone can do with a bit of training, but actually where we really earn our big bucks is the communication. I'm not sure about the stats, but a hell of a lot of complaints are purely down to communication. And if you talk to your patients and their families well and get their rapport, this is why I do a clinic. I wouldn't ever embolize someone's uterus without seeing them in clinic, because there are serious complications these are young, healthy, fit women in their 40s. And if you screw up them, they are going to sue you. Yeah. Whereas if you've explained their complications, you've got a rapport with them, they trust you, you are doing absolutely your best. And if something goes wrong, my God, I'm so sorry. They will not sue you as quickly, maybe, but they will, because they understand that you've counselled them and they trust you and you've done your best and they know you have. Whereas if you've just been flippant and walked in and then you're in a whole heap of problems.
And I think the stat was 70%. 70% of all powers complaints and stuff is due to communication.
You see when I heard that, I was shocked. Stereotypical specialties where, let's say, some surgeons are very good at operating, but maybe not good at communicating. What's annoying is, what would you want? Would you want a really gifted technical surgeon who can't talk? Or do you want the really good gift of the gab who's actually really rubbish with a knife? And it's really difficult because annoyingly, you'll trust the guy that talks nicely, even though he's terrible surgeon. Whereas the guy that's stereotypical arse is actually a really bloody good surgeon who just doesn't talk very nicely. And there's got to be a happy medium, and hopefully we all understand that.
I know, definitely. But Neil, I think we've taken up enough of your time. We want to thank you so much for taking the time out to speak to us, sharing about your journey, your day-to-day life, the stuff that you've been involved in. A massive thank you for taking the time out to come onto the show. We really appreciate it.
No worries at all. Thanks for your time. And I think IR is there's a lot more information out there about what exactly we do and how we do it. And I think BSIRT, IR juniors are doing a great job in advertising what we do, and particularly at kind of foundation level and trying to engage with medical students about the nitty gritties. And I'm actually running a conference in the 3rd of March here in Coventry about what IR is and everything. So I think, watch this space for IR.
Absolutely. We'll be sure to definitely post this and get it out there, especially your conference as well. So thank you so much, Neil, for your time. Thank you so much.